from the studios on the Daytona Beach Community College East Campus.
Hi, I'm Dr. Mark Salzberg, and welcome to Pet Owners Hotline. Tonight we have Dr. Peck from Affiliated Veterinary Specialists in Maitland, and he's going to talk about common orthopedic problems with your pet. Welcome to the show, Dr. Peck.
Thanks for having me.
Just a reminder, this is a live call-in show, and I invite you to call in with your questions you have about your pet. Our number is 1-800-901-9238. Dr. Peck, tell me a little bit about yourself and then a little bit about your practice.
Well, what I do at our practice is a purely referral practice, and so we see cases that are referred by your family's veterinarian that are cases that they're not comfortable managing or they need additional help managing. And we have specialties in surgery, internal medicine, neurology, radiology. We also do physical therapy or rehab, and there are also specialists on same site with dermatology and ophthalmology. I do just orthopedic surgery pretty much in our practice. Okay,
they're going to show some, they can look a little bit. You can talk a little bit about the different areas that you guys do?
Well, in terms of diagnostic capabilities and such, that's an area where we have pretty much anything you would have at a human hospital or an academic institution, including CT scan, which you're seeing right here. We have ultrasound, MRI. This is the CT control room you would see where you would be sitting while a patient is undergoing a CT. There's ultrasound, cardiac ultrasound being done there by one of our radiologists. We have 3 board-certified radiologists as well. We also have MRI, nuclear imaging, what's also called scintigraphy, as well as radiation therapy. There's one of our surgeons, Dr. Madden, preparing for surgery. We've got 4 operating rooms. All of our OR suites are similar, except that the one that you saw previously is one that has our arthroscopy tower, because we've been doing a lot more arthroscopy, doing minimally invasive stuff these days. We also have a veterinary dentist, a board-certified veterinary dentist that comes in, spends about a week with us each month. So we've got a lot of variety in terms of specialties, probably more specialists on the clinic floor at any given point in time than most academic institutions have on the clinic floor at any given point in time.
Excellent. Let's and here we get some more preparation here. I guess some suture removal and stuff like that. So you have, and again, you said you have all these different things. Just kind of like a human hospital here in terms of all the available technology that you have.
The technology is pretty much the same. The space requirements aren't nearly as demanding because each patient, or 1 or 2 patients per large 500 square foot room. Our patients obviously fit in cages, so we need less area. So you see what we've got here is rehabilitation as well, or physical therapy, using underwater treadmill. There's a lot of other things that we do in addition for part of the rehab, but we've got technicians as well as one of our surgeons, Dr. Tan, who is specifically dedicated to the physical therapy rehab.
Excellent. So that's it's a nifty practice. I've actually been there, and it's amazing how much of those things are available now in veterinary medicine that not too many years weren't available. So
private referral practices have really only been around substantially for the last 15 years or so. People used to only be able to get this type of advanced treatment at academic institutions only. There'd be maybe a surgeon around somewhere by himself, not with other specialties, so you didn't have the ability to consult with other specialists at that same level.
Excellent. So now we're going to talk about some kind of specific areas today. Specifically, I guess, is orthopedic issues. Right. Predominantly dogs, but I guess also sometimes cats. So let's talk a little bit about the different things you're gonna mention and common orthopedic problems.
Right. Probably the 3 most common things that I deal with on a day-to-day basis are knee problems, specifically cruciate ligament injuries. People often hear that referred to as ACL injuries. In people it's called the anterior cruciate ligament. In dogs it's called the cranial cruciate ligament. Things you hear, football players, skiing injuries, that sort of thing. Also hip dysplasia is another common thing that we see. Pretty much every day. So dogs with cruciate injuries or knee injuries, as well as hereditary hip problems, are some of the most common things that we see.
Okay.
In dogs, cruciate ligaments don't occur for the same reason they do in people. Most people say, my dog ruptured his cruciate ligament, injured his cruciate ligament. Well, there may have been the straw that broke the camel's back, but typically dogs have a degenerative process within their ligaments that degenerates over time until it ultimately reaches failure. And the downside to that is if it's going on in one knee, real good chance it's going on in the other knee. And it's not something you did, it's not something the dog did, it's just something innate in that patient. And so if you want to look at this model, what we're looking at here is we've got a knee. I don't know if he's zoomed in on that. And here's the femur or thigh bone, and there's the tibia or shin bone. There's the kneecap. I don't know if he's zoomed in on that. And here's the femur or thigh bone, and there's the tibia or shin bone. There's the kneecap, and the cruciate ligament is inside the joint right here. It's marked in blue. And the main job of that ligament, the cranial cruciate ligament, is to prevent the tibia or shin bone from shifting forward relative to the femur. So if I can do this on physical examination, which is what we do, it's called the cranial drawer test, or we also do a test called tibial thrust. If I can shift that tibia forward relative to that femur, that tells me that the cruciate is torn. So people are often saying, well, why don't you have to take x-rays in order to tell me that my dog has a ruptured cruciate? How can you just touch my dog for 10 seconds and know that's the case? Well, this is a pretty straightforward diagnosis typically. If we get this, then we know that that ligament has to be torn. And so there are basically two surgeries that we can do for that. In dogs that are over 30 pounds or dogs under 30 pounds that are particularly active, our first choice is a procedure called the Tplo, which stands for tibial plateau leveling osteotomy, which you can see on this model. So if this is the foot, and here's the ankle or hock, and there's the knee, there's a downhill slope on the back of the tibia. If you look right here, there's a downhill slope on the back of the tibia. And every time the patient bears weight, the calf muscles, which go from here to here, those muscles contract, and the round end of this femur goes down that downhill slope. So it's shifting forward. That's called tibial thrust, which occurs during weight bearing. What we do with the Tplo is rather than try to replace the function of the ligament, which is difficult to do well, we eliminate the need for the ligament by elevating that downhill slope. And how we do that, if you zoom back in on this, we make a semicircular cut through the bone right along the junction where the blue and white is. Make a semicircular cut through the bone, which allows me to, sorry for just a second, rotate that slope so that it's no longer downhill. And then when the patient bears weight, that no longer can shift forward. And we stabilize that using a plate and screws.
You actually have an x-ray, I think, of some of this picture, too.
Yeah, we have an x-ray of the Tplo, if you can cue that up. There we go. And that basically shows, that's a preoperative image. There are two images there. The more horizontal of the line is basically the measure of the downhill slope, which tells us how much we need to rotate it. So the dog that has the R marker on it, that slope is not nearly as steep as the one that has the left marker on it. So we'd have to rotate the one that has the left marker substantially more in order to eliminate that thrust or that forward motion of the tibia. And I've got, I can show you basically a model of the bone that has had the Tplo procedure done. So we've got the semicircular cut right here, and then this would be basically the bone plate that we would be using to stabilize that after the cut has been made.
Excellent. I think we're gonna take a phone call.
Okay.
Go ahead, caller. You're on the air. Hello.
Hi.
Hey, how are you this evening?
Fine, thank you.
What's your question for us?
Hi, my question is, I have a Chinese, and he keeps licking his paws in between his toes, and he's feverishly licking them at times, and it's beginning to make me wonder what's bothering him.
Okay. How old is this dog?
He's 2 years old.
2 years old. Okay. Dr. Peck doesn't probably need to answer this one because it's not specifically a surgery question. It's a good chance that this may be a condition associated with allergies. Dogs will often lick their feet between their toes associated with allergic conditions. Allergies to pollens, dust, mold, fleas, all those things can sometimes lead to that. Now, there are other issues that may also be associated with that. Sometimes infections, yeast infections, bacterial infections in the feet, things like that can also do it. But frequently, if it's all the feet that are affected, it's often associated with allergies. So you probably should see your veterinarian. They can often diagnose the issue and treat the problem. So good question. Now we'll go back to some orthopedics.
Okay.
So basically what you did by changing that angle is that when that leg hits the other one, it doesn't want to slide backwards anymore.
Exactly.
So it hits down. Now you said there's another surgery for smaller dogs?
Yeah, we could do it on larger dogs as well. In fact, we can do it on dogs over 120 pounds. It's just that in general, the Tplo tends to give us the most rapid and most complete return to function with the slowest progression of arthritic change. So it tends to be our first choice for large breed dogs or even smaller dogs that are extremely active, especially if you've got agility dogs. that are going to be demanding quite a lot from their knees. That would tend to be our first choice. Probably the less active and smaller the dog, the less dramatic would be the difference that I would expect between the two surgeries. So the other surgery that we can do, if we pan in on this model, as you remember, I mentioned that what we're trying to prevent is from the tibia from shifting forward relative to the femur. So if I want to stop this motion, what we do is we pass a heavy gauge suture that's made of nylon that goes from here to here, and we tie it back on itself so that it's basically acting as a tether to physically restrain that motion. Now that suture is going to stretch over time. That doesn't mean it's failed. That just means it's stretched. But what we're really relying on more long-term with this procedure is for the body to lay down enough scar tissue to help stabilize the joint. That's not a bad surgery. It's just not generally our first choice for dogs that are going to place greater demands on their knee. Procedure is for the body to lay down enough scar tissue to help stabilize the joint. That's not a bad surgery. It's just not generally our first choice for dogs that are going to place greater demands on their knees.
And I know that and sort of replacement things were the ones that were done for many, many years until this technique was invented.
Right,
I guess,
right.
Okay, what about, now there's another, since we're on, you want to go to hips now? Okay,
sure.
Let's talk about hips.
Well, I think we've got an x-ray of a dog that has hip dysplasia. And most people have heard of hip dysplasia, at least the pet-owning public has heard of hip dysplasia. Most of the time, dogs with hip dysplasia have both hips affected. The image that you're looking at is a good one to look at for comparison purposes because it's a dog that only has what's called unilateral hip dysplasia, or hip dysplasia only on one side. It should be fairly obvious which is the normal hip. It's the one that looks like it's got a shorter leg, but that leg isn't actually shorter. It looks shorter because they can't extend the leg because it's too uncomfortable or there's too much scar tissue around the joint as well to allow hip extension, and that's a very deformed hip. And once we have arthritic changes which result from hip dysplasia, which itself results from laxity or looseness in the joint, the dog is born with a hip that appears normal, but there's looseness and the body doesn't like the looseness and the bones start becoming deformed. Once the bones are deformed, you basically have two options if surgery is necessary. And I say if surgery is necessary because the presence of hip dysplasia doesn't mean surgery will be needed. We only recommend it if clinical signs are impacting the dog's quality of life as the owner perceives it. And once that's the case, we've got the option of either a total hip replacement or a salvage procedure called an FHO, or femoral head and neck ostectomy. Total hip replacement is my first choice because it's more fun, and also tends to give us a more complete, or in general gives us a normal hip, a normal functioning hip. So from my perspective, my expectation for a dog that gets a total hip replacement is that dog acts as if that hip was normal, which isn't what you typically expect. If your grandmother gets a total hip replacement, you're not going to expect that she's going to go out and run a marathon. But you have to figure that most dogs that get hip replacements are 3 or 4 years old, so the equivalent of someone in their 20s or 30s. So my expectation is that dog will function perfectly normal and be able to do anything that it's supposed to do. I've had dogs go back to search and rescue, certainly agility and that sort of thing. And when we talk about a total hip replacement in dogs, it's the same as it is in people. We're replacing both the ball and the socket. If you want to take a look at this model that we've got here, here is the socket component right here. So we've reamed out the socket, so an abnormal one would look like this. And we ream it out so it's a perfect press fit for a new socket. And we basically hammer that socket into place, and it's wedged in there. It's what's called a press fit. And then we also replace the ball from the ball and socket joint. So here's the femur. And we've got a stem going down into the shaft of the femur, and then we've got the ball that will wedge onto that stem. We've got multiple different size balls and necks that can fit into there because we're going to have different amounts of muscle tension. It gives us a lot more ability to adjust our surgery for the dog we're working on. It's not a one-size-fits-all. And so ultimately we've got a brand new hip with a new ball and socket, which in dogs anywhere from 6 months of age up to 12 years of age should last the life of that pet. And we've got a couple of additional x-rays of a dog that had total hip replacement on both hips, if you want to take a look at what the x-ray looks like for a dog with a total hip replacement.
Now, does it matter how severe? I mean, you were showing this picture, you were showing this bone that had the real profound, oh, this is the dog with the total.
Yeah, that's a dog that's had 2 total hip replacements. About 85% of dogs that have hip dysplasia, even if both sides are affected on x-rays, only ever get one side done. And it's not because the people didn't feel like doing the other side because they just didn't want to give their dog more relief. It's because the dogs are so dramatically improved after just one side that the owners typically don't feel they need to do the second side. We could do the second side. I usually like to wait at least 4 months, but we can wait 4 months. We could wait 5 or 6 years, and we do it if they feel that they need it. You were asking about does severity have any impact on whether or not we can do a hip replacement, and no, it doesn't. The more severe and more dramatic the changes are, may make my job a little bit more difficult in terms of getting things positioned just right, but that's my problem.
Right.
The severity of the hip changes on the x-rays doesn't impact whether or not the patient can have or cannot have total hip replacement. The only thing that may impact it some is if the hip has become dislocated and it's been sitting, the ball has been sitting above the level of the socket for a very long period of time. That makes it very hard to get the ball back into the socket, and sometimes no matter what we do, we get it back in there and a few days later it wants to pop back out. And so that would be, those are cases that are higher risk cases. They are very often and most often successful, but the risks are a bit higher in those cases. Normally we say probably about a 7% risk of a complication that would require additional surgery. But in dogs that have a situation like that where it's been dislocated for an extended period of time, I'd probably even double or triple that, but still, a reasonable level of risk if the owner is willing to assume that.
So the thing that holds it down is just the normal, natural
the muscles surrounding
like
the joint. And so that also brings up a good point about the other surgery that can be done for dogs with end-stage hip disease. That's a surgery that's called an FHO, or femoral head and neck ostectomy. And what we do with that surgery, if we pretend that this is the ball from the ball and socket, there's obviously the ball from a hip replacement, but that's the equivalent of the FHO, or femoral head and neck ostectomy. The sole purpose of that procedure is to eliminate the pain of bone-on-bone contact. What's holding things in place when we do that surgery are the muscles that surround the joint. The gluteal muscles, or the butt muscles, and the rotators of the hip are holding things in place. And scar tissue will also form or interpose between the femur or thigh bone and the hip socket to prevent rubbing of bone on bone. Now, those dogs won't function at a normal level, but they should be pain-free. And that's a picture of an FHO right there. You can see the bluish or purple line where the cut has been made, so that we've eliminated the possibility of the ball rubbing, or the femur rubbing against the socket after the surgery.
And then these dogs form a false joint in there at some point, right?
Well, I wouldn't quite call it a false joint. I mean, from the standpoint of when we say that, people say, oh, can't they redevelop arthritis? And no, the answer is no, because there's not really any direct interaction of the femur or thigh bone and the socket anymore. It's strictly the struts surrounding the joint that are holding things in place. And it won't be a solid lock. You don't have the solid lock of a ball in a socket. The femur is able to float, basically, relative to the pelvis.
Okay, excellent. Now, what about just, I know we're going to obviously talk about orthopedic surgery, but how about some other issues with, just anti-inflammatory stuff like that? I mean, again, do you sometimes just say, this isn't bad enough, let's just try?
Oh, absolutely. Typically for cruciate ruptures, we're going to be recommending surgery. I mean, are there situations where people can't pursue surgery for whatever reason? Or probably even more commonly, dogs that have hip dysplasia and maybe occasionally have clinical signs. For example, they went to the dog park and they were just playing hog wild all day, and they're sore the next day. Does that dog need a hip replacement? Well, if it's normal pretty much all the time, except after that's happened, can we do one? Sure. Does he need a hip replacement at that point? Not necessarily. And so those patients can be managed with anti-inflammatories, and there's multiple anti-inflammatories out there now. The drug companies, I guess, have seen that the veterinary market is a nice niche market for them. So you've probably heard of Rimadyl, Deramax, Previcox, Etagesic, Metacam, and I'm probably missing one or two others. I don't think any of the surgeons in our practice, Previcox, Etagesic, Metacam, and I'm probably missing one or two others. I don't think any of the surgeons in our practice feel that one is truly superior to any of the others. Some dogs respond better to one than the others. Years ago, a few years back, people were real worried about Rimadyl. It was really the first non-steroidal anti-inflammatory, or NSAID, that was out there specifically for the veterinary market. And people were saying, oh, you can't give it to dogs, it'll cause liver disease, it's going to kill your dog. That's not true. The problem that we tend to run into is when people continue to give a medication despite clinical signs that indicate that that dog is having problems with that medication. Loss of appetite, vomiting, diarrhea, yet they're still giving the medication, probably because they didn't attribute it to the medication,
Right.
obviously. If you stop giving it at the early onset of signs, you're probably going to be okay. I'm not 100% of the time, but I mean, we've been using these medications for years and years and years now, and they work very well. So we have the anti-inflammatories, and then you have what has gone through multiple different names. They call them nutraceuticals, they call them disease-modifying agents of osteoarthritis, but what most people know them as are the glucosamines, chondroitins, something else called MSM, and now probably most importantly, but doesn't get a lot of press yet, is a type of a fatty acid called eicosapentaenoic acid, or EPA. It's an omega fatty acid that is at higher levels in fish products, but it's not the only one in fish products, and some fish products have a higher concentration of it than others. What they're finding, current research is finding, is that probably is one of the more important modifiers of the arthritic process in terms of trying to slow the progression of arthritis. Regardless of what people have heard or been told, none of these generate new cartilage. They may decrease the rate of degeneration, and they may also have a separate anti-inflammatory effect different than what the NSAIDs have, but they do not rebuild new cartilage. They're not going to take an abnormal joint and turn it into a normal joint.
Hold that thought. I'm going to come back and ask you a little bit more, but we're going to go to the phones again. We have another caller. Go ahead, caller. You're on the air. Hello.
Hello.
How are you this evening?
Hi, I'm doing fine.
Good. What's your question?
I have a 4-year-old English Bulldog. She is 54 pounds, and she took off after a squirrel yesterday, and now her rear left leg, she's having pain and hobbling with it. And I'm wondering how long we can go just to see if it will take care of itself before we should go and get her checked out.
Okay. Well, I would be the front line, but I'm going to let Dr. Peck answer that question, what he thinks, how long you should go.
Yeah. I mean, certainly it makes sense to me to go ahead and have it evaluated by your family veterinarian. Because if it is, in fact, what it sounds to me like, because the history that you've described fits with what we hear multiple times a day, every day, in dogs that have ruptured cruciate ligaments. I'm not going to suggest that I know for a fact that your dog ruptured its cruciate ligament, but that is a fairly likely scenario based on the history that you described. Your veterinarian should be able to tell you, yes, your dog has a cruciate rupture, or no, your dog doesn't have a cruciate rupture. One thing that makes that a little bit difficult sometimes is very early on, it may be that your dog only had a partial tear of the cruciate ligament. Therefore, it may not be possible or easy to detect that drawer sign that I described before, where we were looking at the model and we were doing this motion. And if you can't get that motion, you can't necessarily assume that there's no damage to that ligament. It may be a partial tear. If it's obvious, if it's an obvious complete tear, your veterinarian ought to be able to detect that. And then at that point, you can decide, well, we know there's surgical options, but we want to give it a couple of weeks. I would say in an English Bulldog, chances are I'd be recommending surgery if there's a complete tear. If you had a Maltese or a cat, I'd say if you want to give it a few weeks and see what kind of function you get, that's not unreasonable. The rate of exacerbation of the clinical signs of the lameness, if you go conservative, if you don't pursue surgery, if it were a cruciate rupture, is going to be much higher, but I'm not going to say that's the case 100% of the time. I'm sure there are plenty of dogs out there that have done quite well short-term and long-term without having had surgery, but the overwhelming majority of cases are going to substantially benefit both short-term and long-term from surgical intervention. But from what you've described, I'd say that would be my best guess, and your veterinarian would probably be the first place to go to find out if that is the obvious answer.
Right, and certainly I think that and again, because I'm sort of the front line, a day or so, she tweaked it, she sprained a little bit, it might get better in a day or so. You probably are okay waiting that,
Yeah.
But if it persists longer than a day or two, you should see it be seen. We're going to have, I think we have time for one more phone call, so we're going to go back to the phones again. Go ahead, caller, you're on the air.
Yeah, I was wondering about post-surgery aftercare of the total hip in terms of rehab or what, something you have to do. Can the dog just go ahead and resume his normal activities?
Okay, great question. We don't have much time, so make it fast.
Well, that is a great question. And with a total hip replacement, the important thing is restriction, because those dogs feel great immediately. The more painful they were before, the better they feel quickly. What I tell people is 8 weeks, absolutely no stairs, no on or off furniture, outside only on a leash. If you have a lot of tile or hardwood, I have you put down area rugs with rubber backing in areas where your dog's going to be. Your dog will feel great. In terms of total hips, almost never do they need rehab to reach their full level of function. Rehab can always help get there more quickly, but with a total hip replacement, by about 3 or 4 weeks after surgery, those dogs are walking typically without any lameness. And what I tell people is if by 6 weeks they're limping at all, something's not right. So it's the restriction, it's your challenge. It's not that the dog is going to have difficulty.
Okay, we're really pressed for time. I just wanted to, real quick, I know that after this surgery you talked about the Tplo. I know it does have a protracted healing time that you guys really want them kind of quiet for a long time. And then again, varying degrees of time after surgery for all of these things. But we can't talk a whole lot about those because we're just about out of time. Dr. Peck, I want to thank you very much for coming here today. I appreciate it.
Well,
I hope that a lot of you got a lot of great information. I even got some good information today. And you know, we talked about a lot of different orthopedic issues. Obviously, we talked mostly about dogs. Cats do have some things like dysplasia. I've seen dysplasia in cats, and they do occur, but same thing goes for them. But we are out of time, and I appreciate you coming on the show, Dr. Peck. If you were unable to have a question answered, you'd like to email us, you can get us at channel15@dvcc.edu. Thank you very much. Have a great evening.